of closing gaps in the care continuum, opportunities to improve substance use disorder care in the federal health programs. And I really want to thank our four witnesses for being here and also for their patience. This is a subject that is dear to many of us. We know the numbers. We know the number of people in our community that are suffering from substance use disorders. We know the substances are the opioids, the stimulants, and the alcohol abuse. We know that these disorders are chronic but treatable. And we know that's affecting every community and every neighborhood in our nation. According to the 2022 U.S. National Survey on Drug Use and Health, a staggering 46.8 million Americans aged 12 and older, or over 16% of our population at that age group, had a substance use disorder in the past year. Of those, 29.5 million had an alcohol use disorder, 27.2 million had a drug use disorder, and 8 million Americans had both. I could give you the numbers of my own state of Maryland, where we have 17.8% of Marylanders aged 12 and older have a substance use disorder. But just as concerning is the death rates from these substance use disorders that have increased steadily over the past decade. Intoxication deaths were jumped from 700, this is in Maryland, from 799 in 2012 to 2,800 in 2021. Nearly 90% of these deaths were a result of drug and alcohol-related intoxication, not just alcohol. Most of these were opioid-related, and of course, because of fentanyl, the death rates are much, much, much higher. So we have a serious challenge in our community. What can we do about it? Well, we did pass the Support Act in 2018 that expanded coverage within Medicaid and Medicare. The CHIP program also covers substance abuse. We had the 21st Century Cures Act that we passed. The consolidation appropriation bills contain programs to deal with substance abuse. So we have been pretty active in trying to provide help. And we have found different approaches have worked in different communities. We have collaborative approaches that are being used to try to bring the different stakeholders together so that they can have an effective program. We've engaged peer review, which has worked well in some of my communities in Maryland. We have emergency crisis centers that try to remove those in crisis from our emergency rooms to a place where they can receive the treatment they need, not as a revolving door, but to treat the basic problems that they have with the abuse. So there's been a lot of different programs that have been used in different communities in my state, and I assume this has been true around the nation. We have our federal tools. Are they adequate? Do we have enough support at the federal level to deal with these issues? Are our insurance coverages adequate to meet the needs that are out there? Is Medicaid and Medicare doing enough? Is the CHIP program doing enough? Can we utilize telehealth more than we've already utilized it? We expanded telehealth greatly during the COVID pandemic. Can we do more to use telehealth services to deal with this crisis? We have a challenge with providers. We have a challenge with providers generally, but in underserved communities, it is a real serious obstacle to getting the type of effective access to care that can make a difference. Rural America, rural Maryland, has challenges getting the professionals they need for all mental health services. So these are some of the questions that we would like to get into a roundtable discussion today. And we couldn't be more pleased than to have the type of experts that we have here today to try to help us work our way through this. Shortly, I am told I will be joined by Senator Daines. He's on his way. But let me, if I might, introduce the witnesses that we have here, and we'll start this discussion going because I don't want to hold up our colleagues any longer. We're going to keep this somewhat informal, so you don't have to worry about the normal admonition that your formal statements will be made part of the record or anything like that. This is going to be a discussion, and we appreciate our witnesses coming to this meeting and sharing their expertise. We have Professor Brandon Soloner Professor is the Bloomberg Professor of American Health in Addiction and Overdose in the Department of Health Policy Management at the Johns Hopkins Bloomberg School of Public Health. His research focuses on access and quality of care for people with mental health and substance use disorders. Professor Soliner leads the evaluation at the Bloomberg Overdose Prevention Initiative, a multi-year investment in overdose reductions focused on 7 states. We have Dr. Malcolm Horn, who received her doctorate in psychology with a teaching emphasis from Walden University. She's a licensed clinical social worker and a licensed by the state of Montana as an addiction counselor. She's also had accreditation as a master level addiction counselor. I know that Senator Daines wants to personally welcome you here to this committee, and when he gets here, he might add some glowing comments about how confident he is in everything that you are doing in regards to his home state. We're also joined by Dr. Sarah Bagley. Dr. Bagley is a primary care physician at Boston Medical Center and is board certified in pediatrics, internal medicine, addiction medicine. She is founder of BMC's Center for Addiction Treatment and Adolescents and Young Adults Who Use Substance, the Catalyst clinical program providing integrated substance use care and primary care for youth, where she continues to see patients. And we are joined by Senator Bennett, who wants to introduce our star witness, our star panel. This is a panel discussion, as you all know. It's not a hearing today. I had to keep on reminding myself of that. But Dr. Christine, you're going to be introduced by Senator Bennett.
Are you ready, Mr. Chairman?
Yes.
What? I can't really do better than star witness, but we'll take it. Thank you, Mr. Chairman, for giving me the opportunity to introduce Dr. Paul Cardin, who was born and raised in Colorado and came back home to practice addiction medicine. Dr. Cardin is an assistant professor of medicine and physician researcher at the University of Colorado School of Medicine in Denver Health. He practices at Westside Family Health Center, a community health center that's part of Denver Health, the Denver area safety net health system. We had a conversation in this room about Denver Health a few weeks ago, but I'm going to about how amazing and awesome it is, but I'm not going to repeat that today. He's uniquely positioned to address the important topic today because he's both a primary care physician and an addiction specialist, and he integrates these two specialties in his patient care. In his clinical practice, he provides holistic, comprehensive care for patients as part of an interdisciplinary team. And despite often being reimbursed for only a fraction of the services that his team provides, Dr. Cardin understands the long-term value of comprehensive care and wraparound services to his patients. In addition to his clinical practice, Dr. Cardin's research in this field provides data-driven evidence that can help us develop effective priorities around substance use and disorder. His most recent research focuses on policies that inhibit access to evidence-based treatment for opioid use disorder in Medicaid, such as prior authorization and insert instability. I'm going to spare you the long amount of research, but ask that it be included in the record. And I know this is also covered in the written testimony. I want to highlight here out loud that Colorado has taken some of the most innovative approaches to the opioid crisis, such as considering a Section 1115 waiver that would allow Medicaid reimbursements for housing and nutrition. Dr. Cardin, thank you for being here to share your expertise. And Mr. Chairman, I'd ask the balance of my introduction be included for the record.
We are on uncharted course here. Professor Soliner.
Chairman Cardin, Ranking Member Daines, members of the Healthcare Subcommittee, thank you for inviting me to speak. My name is Brendan Sloner, and I'm a Bloomberg Professor of American Health at Johns Hopkins University. In recent years, my team has interviewed thousands of people with substance use disorders to understand what they need from services. We've also done in-depth studies in settings like rehabilitation facilities, hospitals, and jails. I'd like to reiterate some of the statistics you mentioned, Senator. 49 million Americans meet criteria for drug or alcohol use disorder, including millions covered by Medicare, Medicaid, and CHIP. Only about 1/4 of those 49 million people received any treatment in the past year. More than 107,000 Americans died of overdose in 2022, the highest number ever recorded. These statistics are related. Unless we can increase access to life-saving treatment, we will continue to see catastrophic outcomes. In my testimony today, I will lay out 3 goals that can guide federal healthcare programs as they respond to this national crisis. Goal number 1, federal healthcare programs should cover services that align with clinical consensus. There has been tremendous progress over the last decade in improving coverage in federal healthcare programs, but major gaps remain. Medicare patients do not have coverage for non-hospital residential treatment. In Medicaid, patients in some states have limited access to methadone and buprenorphine, key medications for treating opioid use disorder. Remaining barriers include unnecessary prior authorization requirements and limited access to telehealth. Congress can push for more uniformity in the standard of care for Medicaid beneficiaries. Goal number 2, federal programs should support beneficiaries when they need care in moments of crisis. Only 1 in 5 survivors of an opioid overdose receives effective treatment with medications in the months following their overdose. 1 in 5. Many of these survivors without treatment go on to die subsequently. Ensuring consistent access to medication treatment after a crisis event may be the single most effective thing that we can do to save lives in federal healthcare programs. Yet, most hospitals still do not provide adequate care with medications for people treated for an opioid overdose. Likewise, only about 1/3 of all residential substance use treatment facilities offer medication treatment. Federal healthcare programs have leverage to require hospitals and residential facilities to meet standards of care as part of their conditions for participation. Congress should expect CMS to do so. Another moment of crisis is incarceration. After release, risk of overdose is more than 20 times higher than the general population. Yet, only 1 in 5 jails can start people on life-saving medication treatment. While treatment is increasing behind bars, it's time to pick up the pace. Medicaid could help accelerate this change and save lives of people returning to their communities. It is a big step forward that CMS is providing waivers to cover the cost of treatment just before release in some states. Congress could expand this coverage and incorporate high standards for effective care in jails and prisons. Goal number 3, federal healthcare programs should reward quality and de-adopt low-value care. Here are some ideas about how to reward quality. Congress should require consistent reporting of quality metrics, including recent HEDIS measures on engagement and retention in care. These measures should be included in value-based payment programs, just as we reward health plans for treating other chronic diseases like diabetes and depression. Another opportunity is to promote innovations in the delivery of care. Across the country, health systems are experimenting with walk-in clinics, mobile treatment, treatment in community health centers. Congress should support demonstrations that test the feasibility and cost-effectiveness of new care delivery models. Now, here's what I mean about de-adopting low-value care. Federal healthcare programs should phase out coverage of ineffective treatments. For example, standalone withdrawal management that does not include continuing care can actually harm patients and increase their risk of overdose. In closing, I know that Congress is asked to consider many proposals to address our substance use crisis. As you deliberate, here are 3 questions to consider for each policy. First, will this proposal dramatically increase the number of Americans receiving life-saving treatment? Second, will this proposal help people in crisis when they need it most? Third, will this proposal promote quality while reducing spending on low-value services that make our overdose crisis worse? Given the scale of this crisis, I urge you to make sure that the answer to each of these questions is yes. Thank you for the opportunity to speak today, and I would be happy to answer any questions you may have.
Well, thank you very much for your testimony. I'm going to recognize Senator Daines, who will give an appropriate introduction for Dr. Horn.
Well, thank you, Mr. Chairman. It's good to be back with you all this afternoon at our first subcommittee event of 2024. Today's topic is arguably one of the most relevant and maybe the most urgent issue facing our country. Substance use disorders continue to rise at alarming rates, and the opioid crisis has reached epidemic proportions in the United States. Congress has made incremental steps to expand access to substance use treatment. But as we will hear from our panel, and we already started to hear those conversations from the doctor, there's a lot more that can be done. We are joined today by some of the leading professionals in addiction and substance abuse, both providers and policy experts. So thanks for all coming here, for being here to inform our discussion with your experience and expertise in this field. And a particular thank you to one of my fellow Montanans, Dr. Malcolm Horn, who's joining us from the Rimrock Foundation in Billings, Montana. Billings is where my mom and dad grew up. My dad married the girl next door in Billings, Montana. Rimrock is an adult inpatient treatment facility with a unique and holistic approach to care. In fact, back in 2019, I was proud to take then Vice President Pence to visit Rimrock and highlight the important work that they do. So as a proud Montanan, Dr. Horn, I'm glad to have you here.
Thank you.
And glad to have you as part of this discussion.
Thank you very much.
We're going to talk more as you get to share testimony, but do thank you for making the trip here to Washington. And Mr. Chairman, I'll yield back to you.
Dr. Horn.
All right. Thank you. Thank you, Chairman Cardin and Senator Daines from my home state for the opportunity to be here. I am the Chief Behavioral Health Officer at Rimrock Foundation, a private nonprofit treatment center in Billings, Montana. We provide the full continuum of care. I am also the president-elect of NADAC, the Association of Addiction Professionals, and I am here on behalf of both organizations. My testimony today will focus on the continuum of care as well as the lack of workforce. As I mentioned, I work at Rimrock. I have been there for 18 years in numerous different roles. And I'm continuously amazed when I travel and speak to others that we are an organization that truly does provide the full continuum of care, meaning that a client can do detox, inpatient, residential, day treatment, intensive outpatient, and individual counseling as a part of their stay. We are also multidisciplinary. We have mid-level providers as well as a physician. We have nurses. We have addiction counselors, mental health counselors, peer support specialists, care coordinators, and we can provide medication-assisted treatment. I am continuously amazed and humbled and grateful that I work in an organization that can provide that full continuum and that clients can get everything they need from one organization. We are small but mighty. We are also an anomaly. Most places do not operate that way. Let me give you an analogy. If I was to go to an emergency room with a broken leg, there would be a whole host of multidisciplinary people to care for me. A tech would take me to the x-ray, a radiologist would look at it, an orthopedist might consult, they might recommend that I need surgery. And then a whole new phalanx of multidisciplinary providers would step in to care for me. I would then be referred and recommended and supported to engage in continuing care, physical therapy, crutches, etc. Additionally, my community will support me in that. My employer will give me time off to go to my physical therapy appointments. People will give me extra time to cross the street and hold the door open for me. Now, let's change that. If I was to walk into an emergency room with a broken leg, none of those providers would say to me, "You have two legs, hop around, you're fine." But when it comes to addiction and mental health, that is exactly what we do. Because we don't necessarily have a set up, endorsed, and accessible continuum of care for people that are struggling with addiction and mental health. When it comes to treating addiction, we must focus more on our continuum of care. We must not only make sure that it is in place, but that it is affordable and that there is a rate of reimbursement that is livable attached to it. So when it comes to treating addiction, we typically do the surgery, if I was to follow my broken leg analogy. We do the surgery in the form of inpatient or residential care. We do not, however, typically provide that follow-up continuing care. It is akin to saying, I'm going to fix the broken leg with surgery, but not provide physical therapy. And then when the broken leg doesn't heal, we typically blame the addict. I have frequently heard people say things like, I guess they just don't want it. I've even heard, meh, it's just another junkie. When we have not set up a continuum of care for them, we have not made it accessible, but yet we blame the patient for not being able to access that care. Part of my problem in endorsing and allowing for that continuum of care is the rates of reimbursement. If I speak to Medicaid and Medicare specifically, Medicaid in Montana, we expanded it. In some ways, that was a good thing. However, the rates of reimbursement are so low that they do not cover the cost of care. If I was to give you an example, for a medically supported detox, most insurance companies give me around $1,100 a day. Medicaid, $298.78. Residential care is around $900 a day from private insurance. Medicaid, around $256. You can literally Medicaid yourself out of business. Medicare has done some great steps to expand what they provide reimbursement for. However, Medicare does not reimburse for peer support services, and most addiction counselors in Montana do not have a master's degree. However, Medicare will only reimburse if an addiction counselor has a master's degree and a certain amount of clinical supervision. So again, we've put it into place, but it's not necessarily accessible. We must do more to support the continuum of care and the people that are struggling with addiction. I am asking for this committee to take these thoughts into their consideration as they move forward. We simply cannot continue to let people have broken legs. We've also got to do more on the prevention side. We can provide the treatment, but not the follow-up care. And we've got to figure out why so many people are breaking their legs in the first place. So I appreciate everybody's time. I encourage you to please have this robust roundtable discussion so that we can continue to have this input, and I appreciate all of your comments and the data. That is what's going to drive the policies, is looking at the numbers. So thank you for your time and consideration and the opportunity to be here.
Thank you, Dr. Horn. Dr. Bagley?
Thank you, Chairman Cardin, Ranking Member Daines, and distinguished members of the Senate Finance Healthcare Subcommittee. My name is Sarah Bagley. I'm a pediatrician and addiction provider at Boston Medical Center and an associate program director for the Graken Fellowship in Addiction Medicine at BMC. I founded the Catalyst program, a multidisciplinary team that provides clinical care to youth with substance use disorders, and my research is focused on minimizing the harms of substance use on youth. BMC is the largest safety net hospital in New England, and through the Graken Center for Addiction at BMC is a national leader in clinical care, research, policy, and advocacy related to substance use disorders. I'm thinking today of the patients who I have cared for over the years, of the teens who have lost multiple friends to overdose, of teens sighing relief when we tell them that we don't kick people out of our program for continued substance use or for relapse, of parents trying to understand what is the right level of treatment for their children, and of the families who have lost their children to overdose. Historically, the youth substance use disorder treatment system has been dominated by expensive, hard-to-access, non-evidence-based models, and dangerous. What youth need is evidence-based care that optimizes their safety and well-being, addresses underlying mental health conditions, allows them to reach their individual potential and achieve their goals. So how are we doing? Well, there are significant gaps in access to care for youth with substance use disorders. In 2022, out of the 1.8 million 12 to 17-year-olds with a substance use disorder, only 8,000 sought treatment. Although the majority of pediatricians agree that they should identify substance use disorders, only 20% think they should treat them in primary care, and fewer prescribe medications for addiction. As a pediatrician in primary care, I understand the tremendous pressures that our providers are under. Solutions to address the continuum must focus on systems, not the individual providers who are already stretched to their limits. What steps can we take to ensure youth have the care that they need? In my opinion, we need to have a different approach when working with youth who have a substance use disorder. I often think of a theme I've heard from patients over the years. I'm not hard to reach, you just don't know how to reach me. Well, it's our job to find youth and to invite them into care. For my patients who have lost friends or loved ones to drug overdose, or experienced the challenges of navigating the system as it's currently designed, we're sending the message that their lives are not valued, and we must change that narrative. So how can we do that? First, we can shift the paradigm of high barrier care to aspire to no barrier care. We can identify and invest in alternative settings where youth are, such as school-based health centers and community drop-in centers, as well as facilitate access to telehealth in schools and support team-based collaborative care. We can reimburse pediatric healthcare providers to offer overdose prevention. Drug overdose is the third leading cause of death among children in the United States. In my state of Massachusetts, among 15 to 19-year-olds who die, 20%, 1 in 5 of them, it's because of an overdose. We have to be doing better. As the toxicity of the drug supply has changed, the ways that we talk to adolescents about drug use must change too. With my patients, I say that no drug use is safest. And then I say, if you're going to use or your friends are going to use, here are the ways that you can minimize the risk of overdose, and I make sure that they have access to naloxone and how to use it. Number 3, ensure youth have access to all medication treatment options for opioid use disorder, including methadone. I completed 9 years of medical training and can start patients in the hospital setting on methadone. And despite this, under current law, I am not permitted to prescribe methadone, a life-saving medication, to my patients in the outpatient setting. A patient asked me this weekend to share with you his frustration, our shared frustration with me not being able to prescribe methadone to him. I cannot capture in words the frustration and the sadness that this brings me. For youth who require a higher level of care, such as inpatient treatment, we must guarantee that it is evidence-based, accessible, and includes addressing co-occurring behavioral health disorders. Reimbursement should depend on quality metrics similar to expectations that we have for other conditions, and treatment should incentivize team-based care, evidence-based practices, facilitating continuing care in the community, and involve the family. I want to end my testimony with some hopeful thoughts. 12 years ago, when I started my fellowship, BMC was one of only 10 institutions in the country to offer addiction medicine fellowships. And now there are 102 accredited programs. I am heartened by this as it reflects the investment we have made in building capacity, starting to build capacity to address substance use disorder. We all need the 3 S's: something to do, someone to love, and something to look forward to. This is something that a patient shared with me recently, but I found out was a common saying, and it stuck with me for its simplicity. When I think about what my job is, in the plainest terms, it's to ensure that the youth I care for have access to all the tools they may need to lead fulfilled lives, develop meaningful relationships, and have hope for their futures. Thank you for the opportunity to testify.
Dr. Bagley, thank you for your testimony. I just want to acknowledge that Senator Wyden, the chair of the Senate Finance Committee, is here. We always appreciate his active engagements on these issues. Dr. Stein?
Thank you. Chairman Cardin, Ranking Member Daines, distinguished members of the committee, thank you for the opportunity to speak with you today. My name is Paul Cardin, and I'm an assistant professor of medicine at the University of Colorado School of Medicine and Denver Health, Denver's safety net health system. I'm honored to provide testimony on how the federal health programs can improve the care of patients with substance use disorders. I have the privilege of practicing primary care and addiction medicine specialist at Community Health Center in Denver, Colorado. I'm also a health services and policy researcher who studies policy issues that influence access to evidence-based treatment for substance use disorders. Every day in my clinical practice, I witness the very things that I study, how insurance policies affect the care of patients with substance use disorders. Drawing from my dual perspective as a physician and researcher, I'll focus my testimony on 2 topics today: insurance barriers to effective care, and acknowledging the complexity of addiction care and paying for what works. I'd like to offer you a window into what it's like for my patients to seek outpatient treatment for opioid use disorder. These patients have decided to pursue treatment despite historically being stigmatized by the medical system. They are often in opioid withdrawal, characterized by severe physical and psychological distress. Treatment with medications for opioid use disorder can quickly relieve these symptoms, rapidly stabilize patients, and reduce their risk by approximately 50%. However, for some patients, immediate treatment with these life-saving medications can be delayed due to insurance barriers, including needing prior authorization. There are only 3 FDA-approved medications to treat opioid use disorder: buprenorphine, methadone, and naltrexone. There are no other first-line treatments that patients should try prior to initiating these efficacious medications. Medicare and Medicaid now cover at least one formulation of each of these 3 medications for opioid use disorder. However, many Medicaid programs continue to impose clinically inappropriate policies that delay or interrupt care. This includes prior authorizations and dose and treatment duration limits for buprenorphine. There is no clinical or economic justification for imposing these non-evidence-based restrictions on these life-saving medications. I'd now like to turn to the topic of acknowledging the complexity of addiction care and paying for what works. At our community health center, I'm part of an interdisciplinary team that provides comprehensive care for our patients. This team includes a registered nurse, a social worker, a substance treatment counselor, and a peer recovery advocate, a person with lived experience of drug use who is now in recovery. Recently, a patient came to my clinic to initiate treatment for opioid and stimulant use disorders. During that visit, all of these team members contributed to the patient's care. The nurse treated the patient's skin wound, the social worker connected them to housing resources, the counselor addressed underlying mental health issues, and the peer recovery advocate discussed the upcoming meetings for people in recovery from addiction. Despite the complexity of the care that was delivered, only a fraction of these services are consistently reimbursable in the federal health programs, and often at rates that undervalue the comprehensive nature of the care. State Medicaid programs vary in their payment for non-physician services. Many services routinely employed in addiction treatment remain uncompensated or are only temporarily grant-funded. Value-based payment models are a promising potential solution, though quality metrics for addiction care remain underdeveloped. To provide the sort of comprehensive care necessary to support patients on their path to recovery, we must be able to pay for the services that meet their needs. I'd like to close by offering 3 policy considerations to improve addiction care in the federal health programs. First, CMS should encourage the removal of non-evidence-based policies such as prior authorization requirements and dose and duration limits for all FDA-approved medications for opioid use disorder. Such medications are life-saving and should be available quickly when patients are seeking to initiate or continue treatment. Second, CMS should consider reimbursement models that promote the comprehensive services needed by many patients struggling with addiction. This includes providing reimbursement for non-physician services, promoting evidence-based practices, and exploring value-based reimbursement models. Third, CMS can continue to promote and test innovative models to improve addiction care. Some of the most promising efforts in this realm seek to address health-related social needs like housing and to provide transitions in care from jail and prison to the community. Testing such innovations will require improved data reporting and quality measurement, which can be incentivized by CMS. Finally, I'll close by noting that it is crucial for policymakers to include the voices and ideas of those with lived experience of addiction in conversations about how to improve their care. Thank you again for inviting me to testify on this important topic, and I look forward to answering your questions.
Well, first of all, I want to thank all 4 of you. I think your testimonies have been extremely helpful, or your discussion, so however you want to characterize your statements. But it's been extremely helpful. Dr. Bagley, I just really want to fully understand why you cannot prescribe methadone outside of a clinical setting. Is it under federal law because of the classification of the drug, or is it a different reason?
Yeah, it's federal law. I mean, this is a place where things are evolving. It is federal law that you have to be a licensed opioid treatment program in order to prescribe or dispense methadone to people who have an opioid use disorder. I can prescribe it for pain, but not for opioid use disorder.
It's because of your state licensing or your federal licensing?
Federal licensing.
This seems a little bit unusual. Well, we'll take a look at that. I think all of you are raising the issue of adequate coverage for a more comprehensive approach that, Dr. Horn, your analogy of a broken leg, I think, really strikes home. I think we can all understand that. So are there good models like you have the Catalyst program is a comprehensive program. How is that funded? How do you get the funding for these different services if they're not standard reimbursements under either government insurance or private insurance?
So the Catalyst program is very similar to these other holistic models. We have pediatricians, a child adolescent addiction psychiatrist, 2 licensed clinical independent social workers, and a nurse. We have been funded through through grants, through foundations, and then gotten SAMHSA dollars through our Department of Public Health in Massachusetts, but in general remain under reimbursed, and in terms of that actually being like a sustainable model without additional grant funding would be not possible.
So, we do have some examples of a more holistic reimbursement structure based upon results. I don't think it's ever been tried in regards to addiction services. I think that's what you all are suggesting, that there needs to be accountability, but a more comprehensive model. How many communities have these comprehensive services available? The challenge is that if you have a Catalyst program, that's one thing, but if you don't, the person needing care is going to go to multiple sources, and therefore you don't really have the advantage of a collective reimbursement structure. So how comprehensive are these more total services available in communities? What you have as Catalyst, is that unusual, or do we have more of those available around the country?
I do think that the Catalyst program is unusual, and I also think that community health centers has been really innovative in being able to create these models of care where you have nurses who are involved in helping to manage patients who have substance use disorders, where you have integrated behavioral health with social workers so that co-occurring mental health disorders can also be addressed. And so I think that although thinking about scale is really important, there are examples of this in the community. I also think leveraging things like telehealth and other models that sort of think about how to get to rural areas, which is also really important in terms of equity, is something we should be thinking about.
And this committee is working on the telehealth. Dr. Sellner, you also mentioned the telehealth issue. But talk a little bit about quality programs. You mentioned something I think has all of our attentions on dealing with high quality programs, but also weeding out low quality programs. How do you do that?
Yeah, thank you very much for the question, Senator. I think that the key thing we need to do is to really quantify how different interventions that are out there are being associated or lack thereof with positive outcomes for patients. I think that we in the field understand that there's a lot of care that's being delivered that's not meeting the expectations of what patients should be getting. And I say this also in the context of there's a lot of care that's really outstanding, and I just want to highlight that everyone on this panel, I think, is providing excellent care, but in the world, there's a lot of programs that are not meeting the needs of patients. We need to have, the first step is measurement, and then the second step is making sure that when programs are not performing, we phase out reimbursement for either the programs or the interventions that are not serving our patients.
I think we all agree, but it's so difficult to implement that type of accountability. Senator Daines?
I know my colleagues are here and I want to ask questions. I'm going to ask 2 questions, one for Dr. Horn, one for Dr. Bagley. Dr. Horn, I had mentioned in my opening comments how fragmented the care continuum is for patients who are seeking treatment, which seems counterproductive if the goal is making care more accessible and also to raise patient retention. Could you speak about the spectrum of services that Rimrock provides for substance abuse treatment, as well as the benefits, the advantages and challenges as well of having these services together under one roof?
Absolutely. Thank you for that question, Senator Daines. So Rimrock can provide, as I said, the full continuum. detox, inpatient residential day treatment for a substance use primary diagnosis. We also really recognize that it's often not just about the substance. If someone comes to treatment and I help them stop drinking, but I didn't help address the underlying post-traumatic stress disorder or the family issues, I really didn't help them, I just took away their coping tool. So we also then provide the mental health counseling, peer support, case management, life skills, things like that that they really need in order to keep going in their life without going back to the substance use. Providing that all under one roof makes it incredibly easy. If I have a client in my office that is on the verge of relapse or is in the midst of a relapse, I can pick up the phone, I can call another department, I can link them that day to another person in the organization. And I know who the person is. It's easy to make that connection. It's hard when it's not within that organization. I think a lot of us can relate. If you have to go to 3 different doctors for one issue, we don't want to follow through. That's frustrating. And then if you factor in the rural aspect, and as a person here who works in a frontier state, it is incredibly hard. Even if I say you did your inpatient treatment, but you can go home to Miles City, Montana, or 2 Montana and do your follow-up care, except that you can't because there aren't providers there. And even if I utilize telehealth, which has a place, a lot of places in Montana don't have adequate internet access. So I, again, have put up a barrier to their continuum of care. Or people may not have enough money to have unlimited data or even a computer. So one therapy session might wipe out their data. Well, then why would they go to the session? So they don't follow through. So those are nuances that I really hope that we can consider and have discussions about how do we improve accessibility of internet, as well as making sure that organizations can easily either within their organization or have a solid working partnership with other organizations to make sure that continuum of care is accessible.
Dr. Horn, that might have been the first time 2 Montana has been uttered here in Washington State.
Montana.
A shout out to 2 Montana. You're speaking my language now. Dr. Bagley, you mentioned your testimony. By the way, the methadone question was something that we've got to get addressed at here as a committee, understand the limitations and constraints you face there. But you mentioned your testimony that overdose has become one of the leading causes of death for children. I think you said it was 3rd leading cause of death in the United States. You also discuss how the drug supply and accessibility has changed drastically in just a few short years due to the concurrent rise of fentanyl. And maybe just a parenthetical question, do you view fentanyl as poisoning or overdose? What's the right terminology?
I use the term overdose.
It seems like it's the smallest amount of fentanyl will kill you. So I just want to make sure we have our terminology correct, but it's a poisoning because I don't know how you OD on it when just the smallest amount would kill you.
Yeah, I think about overdose because I think about overdose as, taking a substance that you're taking, because you can have an unintentional overdose. So oftentimes we will call that an unintentional overdose. Yeah. So in that way, I'm sort of thinking about a kid who's sort of unintentionally picking up a pill, doesn't realize that they're doing it, and then has this tragic consequence.
Thank you. Just want to make sure we get our terminology right here. But we've seen the dramatic rise of fentanyl, how easy it is to access over social media, making it easier for teens and adolescents, the tragic stories we hear of teens who are dropped over dead in their driveways, and so forth. It's awful. Could you elaborate on some of the nuances of providing substance use treatment to children and young adults and specific barriers that exist for young people who are seeking treatment?
Yeah, thank you so much for that question, Senator Daines. I think to answer the question about overdose, one really important, I think, consideration is that youth are at risk for overdose even if they don't have an opioid use disorder. And so this idea of trying to empower and reimburse pediatricians and other people who are sort of in contact with youth to teach them about the risks of overdose and then how to recognize and respond to an overdose is really important, because if we only focus on youth who have an opioid use disorder or maybe even have a co-occurring mental health disorder, we're going to miss these other kids who are just at risk. And then when you think about the even higher risk youth who have a substance use disorders, there are multiple barriers in terms of being able to access treatment. We simply don't have enough treatment for youth in this country. We have done a tremendous job in a lot of ways in terms of prevention, which we should celebrate. But when we actually recently did a study, we used the SAMHSA treatment locator and did like a secret shopper study where we called and pretended to be a parent. And many of the programs identified through the SAMHSA treatment locator did not take adolescents. Even fewer accepted youth who had Medicaid. And then in most treatment facilities are not available, less than half the states in the US have treatment beds for adolescents and are able to also prescribe life-saving buprenorphine. So access is an issue. The workforce, as we've talked about, is a major issue. And then I also think sort of finding ways to invite families and other support networks into care is also a barrier. Our kids don't live in vacuums, right? They're part of families, they're part of communities, they're part of schools. We really need to think more creatively about leveraging the families and social networks to be part of the solution, and then think about what it would look like to reimburse for working with a family, even if the kid isn't ready for treatment. And so I think those are some of the, those are some barriers, but I think hopefully some ways that we can start to think about doing things differently to address this growing crisis.
Thanks, Dr. Bagley. Mr. Chairman, you're back.
Senator Hassan.
Well, thank you, Mr. Chairman, and to the ranking member for holding this roundtable. Thank you to our witnesses for not only being here today and for superb testimony that's really helpful. Because you come from a perspective of such knowledge and expertise and care. But just thank you for what you do day in and day out to help us. And for the subcommittee's information, Senator Markey, through Help Committee jurisdiction, and I have a bill that would modernize access to methadone, among other things. So we would look forward to working with members of finance to move that modernization bill forward. I have 3 questions, and they touch on things we've already talked about, but I wanted to give you all just a chance to add whatever makes sense to you. So Dr. Saloner, starting with you. 2 years ago, we passed a new law that increased by tenfold the number of providers who are allowed to prescribe medication to treat opioid addiction. As you know, this medication cuts the craving for drugs, and it's the gold standard for addiction treatment. Last month, we passed into law a permanent requirement for Medicaid to cover this treatment. However, there continue to be administrative barriers that prevent many doctors and nurses from prescribing medication to treat addiction, especially for patients with Medicaid, as you've all pointed out. Researchers have found that many Medicaid plans require lengthy approval processes for patients who need addiction treatment, especially for patients who need higher doses of the medication. So can you talk about how management tools such as prior authorization continue to deter providers from treating addiction?
Thank you, Senator Hassan, for that question. And also, thank you very much for your leadership on these issues. It's really appreciated.
Thank you.
You're absolutely right. Prior authorization is now one of the biggest barriers to, first of all, starting patients on medication treatment, and second of all, sustaining their treatment. And I really want to emphasize both of those points because prior authorization sometimes kicks in at about 180 days. Clinically, there's no reason to hold up treatment at that interval. Treatment needs to go on for as long as treatment needs to go on to be effective. You also mentioned this issue of dosage. Many state Medicaid programs continue to restrict patients to dosage levels that might have made sense in the era before fentanyl. Now, with fentanyl in the drug supply, it's really critical that patients have the ability to get dosed at a level that helps to achieve symptom relief. So really, the best people who have the greatest expertise to make these decisions are the clinicians. And it's not effective. It's not in the best interest of patients to continue to have all of these additional barriers imposed by prior authorization.
Thank you. Dr. Christine, in New Hampshire, all 10 of our community health centers provide addiction care, including medication to treat addiction. In 2022, our health centers provided specialized services to nearly 5,000 patients who needed mental health or addiction treatment. I recently visited Goodwin Community Health in Somersworth, New Hampshire, where patients can receive both physical and mental health care under one roof. So can you talk about the impact that this integrated model of care has for patients? And also, how can Congress help do more to help community providers integrate mental health and addiction care?
Thank you, Senator, for that question. And I'm glad you got to visit a community health center to see how it works.
Yeah.
I will say, as Dr. Bagley had mentioned, it really is an ideal setup for providing holistic care to patients. So as I mentioned in my testimony, I am part of an interdisciplinary team. And quite frankly, I see the patient, I can prescribe them medications, but a huge component of people's care is all of the other team members who are doing the work. It's the peer navigator tracking them down if they've fallen out of care. It's the nurse calling them to make sure that they're coming in for their doses. It's the social worker making sure they're getting plugged into housing. And all of those services are available in a community health center setting. I will also note that we've talked about methadone access as well. Community health centers are unique in that they also have integrated pharmacies. And so to the extent that a provider like me would be able to prescribe methadone, I could do that right out of my primary care clinic so that patients can indeed receive all of their care under one roof, their primary care and their addiction care.
Thank you. And finally, Dr. Bagley, a question for you. Because, and you mentioned it, another barrier to expanding access to addiction care is stigma. Many patients find it difficult to ask for help with addiction, and many doctors who focus on physical health feel unprepared or perhaps are unwilling to treat patients with addiction. Sometimes when I talk to doctors, they phrase it, these patients are very complicated and I don't have time and we don't know what to do. What can we do to combat stigma in the medical community and the general public?
Thank you so much for that question. There are a couple of things that we can do. I think one is thinking about the workforce and thinking about sort of integrating, into general medical education, into schools of social work, into people who are training to be psychologists, into nursing school. And so this idea of really normalizing it. This is something that you should be learning as part of whatever your training is, because you may be touching people and caring for people who have substance use disorders. And I do think that it takes time. That is time to invest in that workforce development, but that makes a difference. As Dr. Cardin mentioned, as Dr. Horn mentioned, these are multidisciplinary teams, and so we need to really invest in everyone. I think also these integrated collaborative teams is also really important because we're normalizing things. We invite people into our community health centers, into our school-based health centers, and we are saying that we are going to provide holistic care for you and really think of you as a whole person and not simply define you as your diagnosis. And then I think, too, sort of thinking about engaging family. I mean, you asked about the public. And so this is, I have been part of a coalition in my city to address substance use disorder. And I think actually finding ways to bring communities together to have frank and sometimes difficult conversations about substance use disorder, and then having communities being able to advocate together to address what's going to work for their community to address the crisis.
Thank you. And I'll just note that what began to work in New Hampshire, which was touched very early by the opioid and fentanyl epidemic for a number of reasons, it has been young people speaking up about it that has begun to destigmatize it the most effectively. And so, when a 10-year-old asks her, Senator, what are you doing about mental health and addiction, Senator, in a meeting, it's a pretty impressive and humbling thing. Thank you.
Senator Cortez Masto.
Thank you. And for the benefit of the committee, the adopting an integrated care model is so important, and that's why Senator Cornyn and I, because of our work here together on this committee, have introduced the Complete Care Act. Welcome you to join us on that, and what it does is expand access to behavioral health services delivered in the primary care setting by helping those providers with the upfront cost of adopting that integrated care model. That's a first step. That's for behavioral health. I suspect and hope that the same integrated model would work for substance use disorder. And you guys are all talking my language because this is the conversation I have in my state. The lack of continuum of care, the challenges we have with the workforce, the stigma associated with behavioral health and substance abuse issues, and this idea that in the United States, what should be happening is that if you have a physical issue or a mental health issue or substance abuse disorder, you should be able to go to a doctor, access that care no matter what it is, be able to afford it, have quality care, and get that support without the stigma, without the silos of how am I going to pay for it? That is our challenge in this country. And the work that you are all doing and the advocacy is going to help us, at least at the federal level, start filling in the gaps in that continuum of care and hopefully overcome this stigma for so many reasons. And so that's why I appreciate the committee and the work that everybody is doing. The other thing I've learned from at least the folks in Nevada, that peer support specialists are key. And I've met so many of them, right? And this makes the difference as well. And so Senator Cassidy and I introduced the Peers in Medicare Act. And again, it's legislation that would expand coverage of peer support services so that people with Medicare can access the care they need. So I guess for all of you, maybe Dr. Cardin, let me start with you. Talk a little bit about why this is crucial. Why we have peer support specialists. Why is it important to integrate this into part of this services for individuals?
Thank you, Senator, for that question. Peer support specialists are crucial to our treatment. These individuals are often the single person on our team that can connect with patients that are especially hard to reach and patients that may have experienced the most stigma in our medical settings to begin with. And so as somebody with lived experience who's been in their shoes, that is really inviting the patient in to treatment in a way that simply those of us without that lived experience can't always do.
And that's true for adults and our youth, correct?
Yeah, I think that is. I think it's true for youth as well. I think you have to be thoughtful about creating systems where youth who are doing that work as peers are supported because they're younger, and so it would look differently. But that credibility and that I think about the way that the patients like sigh and relax when they are able to talk to someone who sort of understands what is going on, and that's like a human thing. Right. And so it just sort of seems like rational then we would have people as part of our teams who would be able to offer that as like a component of the treatment, the care that we are actually offering to people.
One final thing, and we haven't touched on, and would like any of you just to weigh in on this. It's maternal health care. Many pregnant, postpartum women with substance use disorders face barriers that may affect their treatment to services. So I would ask any of you to weigh in. Are there services or treatment strategies that we should be talking about as it pertains to maternal care as well? Is there a uniqueness around that we're not aware of, that we're lacking in our continuum of care here? And Dr. Soloner?
I'd be happy to offer some comments. I'm sure the other panelists have some as well. I think it's important to emphasize, first of all, that for pregnant people, medications for opioid use disorder are effective. And there has historically been a lot of stigma about starting people in pregnancy on medications. And I think a lot of it has to do with this unfortunate narrative that we can have babies that are born with addiction. And that's just absolutely not correct medically or scientifically. There is a syndrome called neonatal abstinence syndrome. It's very easy to manage. I don't know if it's very easy, but it's manageable clinically, and it puts mom and baby on the right track. So I think making sure that the same interventions that we're recommending for everyone else are offered to pregnant people is really one critical piece of the puzzle around pregnancy.
And is there a barrier to affordability through Medicare or Medicaid because
I would say that Medicaid has been a terrific system for pregnant people. I think that it's important that we recognize that Medicaid expansion is catching more people during pregnancy and taking steps to ensure that people maintain their Medicaid coverage during that incredibly vulnerable period of time. So I would just say that Medicaid is a major part of that solution.
And it is in Nevada, believe me, we've just extended it. So thank you. Thank you, Mr. Chairman.
Senator Stabenow.
Well, thank you very much, Mr. Chairman. This is a really important discussion, roundtable, as whatever we are calling it. But it's a very important discussion. Let me just say, first of all of these issues are so critical, and thank you all for being involved in this. We are making some progress in some areas, and I want to speak to that. And I know, Dr. Horn, you are specifically in Montana involved in trying to move forward a new model that we have that really hasn't been talked about yet today, which is, I think, is just important not to overlook, and that is a certified community behavioral health center model based on health centers, basically. It's the health center model, fully funded under Medicaid, prospective payment, and so on, but for behavioral health, mental health, and substance use disorder services. And so, and I know in Michigan now, Michigan is one of the states, the 10 states that are designated for full Medicaid reimbursement, enhanced Medicaid, about a 90% match, and prospective payment. And the health center and the CCBHC are more than likely in the same place. They're integrated. So, I mean, we are moving in a number of fronts. 500 clinics nationwide, 10 more states to be announced in June. I know Montana's working on that to be one of those states. I hope you will be one of those states. But we do have a comprehensive model not based on the patient's level of illness, but on the clinic. On providing comprehensive care. In Michigan, we now are in a situation where about a third of the folks that walk in the door, there's no requirement to pay. This is anybody can walk in the door, they are seen the same day, about a third of the time, and the rest within about 10 days, which is required. So I'm hopeful we're going to move on this model forward as quickly as we can, because the good news is under the gun safety bill we passed a year ago, we fully funded this under Medicaid. So I'm hopeful all of you will be reaching out in your states to be connecting with what's happening. But Dr. Horn, I'm excited to hear that Rimrock is in the process, that you're part of this effort in Montana. And I wondered if you could tell us how you think this, what we say CCBHC, it's a big mouthful, how this model would address the gaps that you see in care continuum, and also about the prospective payment system, which I've heard for so long is so important to be able to meet reimbursement centers and have quality staff and be able to pay staff and so on. But I'm wondering if you could speak to both the overall continuum of care, why you think this is important, why you're involved in trying to have this model brought to Montana, but also why you think the prospective payment system appropriate is a better way to do this in terms of reimbursing substance use disorder as well as mental health.
Thank you. Yes, having a CCBHC model is literally life-saving and a game changer. So the CCBHC model, very similar to an FQHC, a federally qualified healthcare center, but on the behavioral health side, provides a continuum, embedded set of services that you are required to provide. And along with that is an enhanced rate of reimbursement, which is why it's so imperative. And I am hopeful that Montana will be one of the states selected. I'm very excited about that. I want that for all 50 states. I mean, why not have that for everybody? If we know that that is the best practice, we should do that. But providing an enhanced rate of reimbursement allows me to have more staff and more qualified staff. Right now, I may have clients that really need medical services or inpatient care, but I can't hire enough nurses to safely bring them in. I can't hire enough counselors to bring them into group. So then we tell people, well, it's going to be 5 weeks until we can get you in. And during that time, they go back to the fentanyl or whatever else they're using, and there's a good chance they will not be able to show up at all for their bed date. So being able to have a better rate of reimbursement allows me to make payroll. It allows me to hire more staff. It allows me to expand services. It might even allow me to provide care in a more integrated way that is more peer support services. We heavily use our peer support services, and we have open positions. So again, I wouldn't have to have so many open positions, which means that translates to more client care, saved lives, and better outcomes. So the CCBHC model is absolutely key in making sure that we address this addiction crisis.
Thank you. Well, let me just say the good news is that we do now have the funding in place. It's being done 10 states at a time to fully create the model and the quality standards and so on. That's
Thank
what
you.
SAMHSA is doing, but it will be all 50 states.
Truly,
if we-
thank you for that.
If we keep moving on this. And I'm hopeful that what we do in the community is ultimately going to be totally coordinated with this transformation. It's in behavioral health service. That's what this is. We're going from grants that stop and start in mental health and substance abuse to a fully integrated system based on healthcare funding, just like FQHCs. And so I hope we're going to be embracing that and moving that as quickly as possible. Thank you.
I just really want to congratulate Senator Stabenow for her leadership in getting this program through the Congress. It was not easy. I can tell you how she nudged us over and over again until we finally got it done, and it really is a game changer. And I think the analogy to qualified health centers is a really good analogy, so really good work. Senator Whitehouse.
Thank you, Chairman, and thank you to all the participants. One of the victories of COVID was telehealth access, particularly for buprenorphine, for people who needed it, and unfortunately it expires at the end of this year. May I report to the world that all 4 of you witnesses would support extending that telehealth access? May the record reflect, well, is there going to be a record?
Well, we have streaming live.
Okay. All right. For what is, all 4 nodded in support, which is good. I think we'd very much like to get that done, Mr. Chairman. Rhode Island has had a pretty unique experience with our incarcerated population. We started a pre-release treatment regime for people scheduled for release, and saw from that a 61% reduction in overdose deaths in that population. That's a big percentage. And yet many incarcerative facilities don't provide that option. So I would like to see if you would support trying to extend that to as many places of incarceration as possible, so they're getting it first. Again, 4 heads nodding. Good, I'm doing really well here. And then to look at getting Medicaid to support those regimes for a period of time, 30 days, perhaps longer, after release, so that somebody isn't stepping out of the incarcerated facility where they get the medication into an environment in which they don't any longer. Would that be a good idea? 4 for 4, yes, great. Okay, the next one's going to be harder. We are looking at a bit of a conflict within the treatment community over expanding the availability of methadone. Now through OPTs, basically, to having any certified physician able to prescribe. And it strikes me that the merits of that proposal depend a lot on the geography of the site. That if you are in Montana, for instance, Dr. Horn, and it's a long way to a treatment center, that being able to go to the nearest certified physician and get a dosage, and to be able to get a fairly considerable dosage so that you can actually go home and not have to make the trek again, could make a lot of sense. You drop that same availability of large dosages for potentially long periods of time into an environment in which treatment is much more locally available, and suddenly the diversion problem begins to increase in prominence. And I would just like to propose, I don't know if any of you are working that problem right now, but it seems to me that there could be a distinction in that program between places where it makes a lot of sense because of access and geography, from places where it actually looks dangerous because of diversion. And if any of you have any thoughts on that, I would appreciate it. My time is pretty much expired, I would say. So if you have an instant thought, I think the chairman will let you share it, but I'd actually really appreciate it if you would communicate in writing with Chairman Cardin's office what your thoughts are on where it's sensible to have this work in different ways, recognizing the different facts on the ground that communities have to face.
This will not work with nodding of the heads. It's not going to work in that situation.
No. This is going to take actually putting pen to paper to.
It's a very
Senator
thoughtful
Cardin's
question, though. I mean, I don't think I would have put it together the way you just did, but there is a concern about diversions. There's no question about it. And yet there is so we've been trying to get the length of prescriptions shortened because of diversion. And now you talk about in areas where you don't have the same services and you need the continuity of care where you need to have a larger amount. It's an interesting point that Senator Whitehouse is raising. So we would be interested if you have a way that could be handled within the regulatory framework of the federal government or by legislation.
Thanks, Chairman.
I'll try to be quick. So, I think one thing is some of the legislation that's being proposed would restrict methadone prescribing to people who are addiction medicine physicians or have specialized training. So it would be like the first step would sort of be more incremental in a way, and to address the sort of concern about sort of a significant increase in prescribing. I think, too, is sort of, as we've just been talking about, sort of these integrated models and people being able to go to places to be able to receive primary care, behavioral health care, work with peer recovery coaches in sort of a non-stigmatized regular healthcare environment. I sort of think about methadone the same way, sort of being able to sort of not silo it and sort of being able to offer it as part of sort of just general regular medical care so that people don't have to like go to the clinic. And feel like it's not just part of the regular health care that they're trying to access.
I think that the problem comes when, because of remote location and lack of access, you're sending somebody away with a fairly considerable dose of methadone to last them for, 2 weeks or a month or whatever the period is. And if somebody's heading out to someplace that's pretty remote in a small town or on a ranch in Montana, then that makes quite a lot of sense. But if you've got an urban community that has lots of people who suddenly have access to lots of methadone, I do think it creates diversion issues in that very different situation that we should try to work our way through. And so that was my suggestion.
Certainly, briefly, because you do have a vote on that. I'll make sure I get you all over for.
I appreciate that. So, Dr. Bagley, you mentioned that you would be able to prescribe it for pain management, but not for somebody who is addicted. Is that right, methadone? So what's the distinction between are there limits for pain management and concerns about diversion?
Regulation. No, every state sort of may have different rules around sort of prescribing of prescription medications, different not really laws, but regulations that sort of guide what I do. But I am allowed to prescribe methadone. I write it on the prescription. Like I would write like methadone and I would write how much, and then I would say for treatment of pain, though, to actually make it very clear that I was not using it to treat opioid use disorder, which is not allowed sort of where we are.
No, and I appreciate that. The only reason I bring it up because it still could be diverted.
Isn't there medical protocol on pain medicines a certain length of time different than for opioid use addiction or not?
We do.
Within the profession, isn't there a different protocols?
Well, that's a great, so we use a much lower dose of methadone when we're using it to treat pain, and we usually use it multiple times a day just because of the way the medication works. So usually it's prescribed 3 times a day at a much lower dose than we use to treat opioid use disorder, which tends to be higher doses. And I would say in the context of fentanyl, we are finding we are needing higher doses of methadone in order to adequately treat people's cravings.
Yeah. Well, this has been the best roundtable discussion the subcommittee has ever held. This set a record. And we thank you all for your cooperation. It's been extremely helpful to us. And I think it gives us the foundation. As I said, I know that Senator Wyden is planning to have a full committee hearing in regards to the methadone, the fentanyl opioid issue. So this will help us in dealing with those issues. The good news, I can't ask you to respond to questions because we're not in a formal committee hearing. So you all are excused. Thank you all very much.